and I've been asked to speak about epidemiology, and so the nice thing is there's not that much data, but that's okay, because you guys just told me how you don't have a lot of data either. Disclosures are as shown. Again, I'll be talking about some off-label investigational use of devices, even though my assignment was more about epidemiology. I can't help myself. I do have to talk about surgery a little bit. Certainly, we are seeing that patients with connective tissue disorders, hereditary thoracic aortic disease, I don't really say connective tissue disorders very much anymore. I fight Lars about that because you guys taught me that, are living longer. And they're living longer because we're recognizing the diseases sooner and we're getting better at taking care of it. You can see in our institution, the number of patients undergoing David's procedures has just exploded over the last 2 decades. We've expanded to more and more patients with bicuspid aortic valves. And this is a rather old paper, over 10 years old, but we had shown in the past in a series of nearly 200 patients with hereditary thoracic aortic disease that the operations are really safe and really durable. But we know that patients who undergo these prophylactic operations still suffer from de novo dissection. We never published this because we didn't have a denominator and we couldn't make it scientific, but this was about 10 years ago. We identified at least over 60 patients who had de novo dissections, type B dissections after having root replacement. A lot of them had their surgery somewhere else, so again, it was hard for us to kind of put this together in a study. But we had that data out there, and it certainly raised an eyebrow for us and opened our eyes. And then these guys published this just recently. Chris Burke and the team, and Shireen Shahoub and the team from the Pacific Northwest, and they looked at 124 patients who had elective root replacement with Marfan syndrome, and 25% of them either had downstream growth of their aorta over 4 centimeters or a type B aortic dissection. And there was a lot of patients with type B aortic dissection, 20% of these in their series. No surprise, the patients who had aortic dissection, their aorta grew at a much faster rate, 0.7 millimeters versus 0.3. But their conclusion was that there was no difference in survival and that this was not necessarily a problem, but you can see it's mostly a data issue. If you have a dissection, your survival changes because your risk of reoperation goes up, the disease becomes much more severe. But nonetheless, they also described the deaths and causes of death in these patients were a little bit different. A lot of aortic causes of death in people who had aortic dissection. And so distal dissections do occur, no surprise. Stanley Crawford told us this, 60 years ago, that no patient with aortic dissection should be considered cured of the disease. And although my assignment was type B dissections, which is something more like this classic type B we see on the left that I thought it was funny, Shireen called the stepchild of dissections the other day, so I had to add this to my slide. We also have the people who have residual dissection after type A dissections. I think we have to consider all of this as sort of being the same complication of the underlying aortic condition. And it is more common, I think, than people appreciate. So again, Shireen wrote this really great paper where they looked at nearly 400 patients with type B aortic dissection, and I was surprised to see that a quarter of them had a hereditary aortic condition. About 10% were syndromic, 18% non-syndromic. The patients did about the same when you saw that when they were treated early. The difference here, these people with non-hereditary conditions did a little worse in this entire cohort. Oftentimes it looks like because their diagnosis was delayed. So at least there's something good about having this hereditary aortic condition. When you have a dissection, people maybe are better at recognizing it and making the diagnosis quicker. But we're teaching the world to be aware of aorta, so that's going to change too. Interesting, when they looked at this subset of 6 families and 29 patients with PRKG1, the type B dissection rate was 40%. So again, we think about these things, and I'm always thinking about them being at risk for type A dissection, root aneurysms, the proximal aortas under all this extra load, and yet we still see a lot of type B dissections in these patients. We need to pay attention to this condition. And so I'll share with you a couple of my own patients. This one was an important story for us, and Shane, the guideline, that statement is awesome. I've been blessed to have Ken Zaka, who's like an amazing guy with a lifetime experience taking care of young people and their families. But when Ken's gone, I don't know, who's going to fill his role. So it's great to have some guidance from experts. And Ken helped me take care of this young lady. Her grandmother had an aneurysm repair when she was very young. She was maybe 8 or 9, and that triggered somebody to look at the whole family, including this young lady. And Ken was following her. At one point, they tested her, and she was found to have an ACTA2 positive variant of unknown significance. Her father had a dissection in 2011. He had no diagnosis except that he had a dissection. He wasn't really great with his follow-up. But along the way, we figured out that they all had this ACTA2 abnormality. And Ken was following her really close. And when she was 18, after he had been watching her for like 10 years, he thought that there was some significant growth. It's hard to sort of appreciate. I honestly don't know how big this aorta is, but I did put the picture up there. It was somewhere in like the 4 centimeter plus range, not that big. But you can see there is effacement of the sinotubular junction. These are some of the subtle things that, I was talking about my RI, not the AI, but my RI, my real intelligence. I don't like that, right? So I didn't argue with Ken. I knew actually her father, I had actually done a redo arch replacement on him. And so we took her to the operating room, and I did a David's procedure. And when I was there, knowing her dad and sort of his natural history, I got a little aggressive, and I did a zone 2 arch. So I did my anastomosis over here and did branches to the nominate and left common carotid. And lo and behold, 3.5 years later, right around New Year's Eve, you can see I got this text from Ken. He said, hey, our girl, we both know her really well, she's a sweetheart, just called me. She's having chest pain. She's on her way to the main campus ED. I told the ED to wait, get a CAT scan immediately. All right, Ken, keep me updated. This is me. And he says, Happy New Year's. You too, Ken. And when she got there, this was her CAT scan. Maybe I just have to click to play. There you go. So proximal repair looks awesome. I'm happy about that. But the dissection is new. And it is de novo, and you can see it started out here on this 3D scan. The tear is kind of out just beyond the subclavian artery. But boy, did I ever feel smart about doing the zone 2 arch in her. I had questioned myself whether it was too much. Thank God she didn't have any additional bad outcome from that. So we were kind of updating each other. Ken says she's got a type B dissection. I kind of knew because I was waiting for the scan as well. But this was my initial approach, was all right, if no malperfusion, we can cool her off with anti-impulse therapy and can determine the best course of therapy after that. And really, TVAR may be a good option, even given her age. And this should be HTAD, without burning any open repair options later, depending on the detail of CT. So, they cooled her off, and in the morning I went and saw her. And then we didn't like the way it looked, so I took her to the OR. And we stent grafted it. And we had a great place to put a stent graft in that fabric, and so we were prepared for it. And then I put a bare stent all the way through the rest of the aorta so we could optimize flow in the true lumen, and she's done great. And this was about, I guess you can see the date, 2021. She's doing really well. She graduated from college, and she's going to be getting married soon. She also was diagnosed with thyroid cancer and had a thyroidectomy, which is totally the worst luck ever, but she's cruised through it because she's an amazing young lady. And so we have to think about sort of those type B dissections, and I'm glad we did in her. We also looked at our ACTA2 patients. We had an experience of 38 of them in Cleveland, and 13 of them had dissections. And you can see a lot of them were type B dissections, actually more than type A's in this group. This may be sort of tainted a little bit because I think some of them were residual type A's, and it was hard to sort of tell what was a type B and what was a type A. But there were new dissections in a lot of these patients, and a lot of reinterventions. So especially the people with dissections, but a lot of our ACTA2 patients had progression of disease in multiple segments of the aorta that required reinterventions, like this guy, who we did a arch frozen elephant trunk, we did TVAR, then I came back, did a thoracoabdominal repair, left some of the infrarenal. Frank Caputo put in a branch stent graft, including a branch to the internal iliac, and I did a valve-sparing root on this guy. So he had like 6 operations. This whole aorta's been replaced, and a lot of these patients have had their whole aorta replaced. We saw the same thing in our Loeys-Dietz population. We have over 50 of them, 33 who underwent surgery, and 6 of whom had a total aortic replacement and multiple operations. You see these 33 patients had 81 cardiovascular operations, and several of them had recurrent dissections, so some new dissections after previous dissection repair. And so we're aggressive about these patients. This is another patient of mine, a young patient with LDS. He's a twin, and he and his brother had David procedures when they were really young, about 12 years old. And then one of the twins had a dissection. They did an open type B repair on him, and he died from complications of that. And then and this was before they met us. So they found us, and they were like, what do we do? The whole family was shook up, of course, and the surgeon was a good surgeon. I don't know all the details of why the guy died, but it was awful. But they came to us, and the other twin, his aorta was a little dilated beyond his old root replacement. And this isn't huge, but it was like 4.3 centimeters. And so, Ken called me, and we operated on him. And I did this hybrid repair. So I replaced his ascending aorta, and I did the Be Safer, which I'm studying in a PSIDE now. We've done this in something like 700 patients, where we put a stent graft in, additional stents in the arteries. And I'm not afraid to use them as long as we secure them and we understand the limitations of that technology. Allowed us to do a quick and easy arch replacement on him, and we're monitoring his descending aorta, which currently looks great. So we're aggressive about them. And we have a lot of these patients with heritable thoracic aortic disease who we've done surgery on the distal aorta. We studied this with Gabe Lohr and some of my residents quite a few years ago. This is an old paper. We probably should update it, but over 10 years ago, we had 527 patients who had undergone some cardiovascular surgery, but 121 who had distal aortic repairs beyond the left subclavian artery, and they did quite well. A big mix of operations, including some TVARs and frozen elephant trunks, a lot more TVARs now. And with a median follow-up over 4 years, we had a lot of these patients required multiple operations, including some of these big thoracoabdominal extensions of the TVAR, and the probability of reintervention is high. Most of these patients had aortic dissections. Once you dissect, you're going to probably need that whole aorta replaced at some time in your life, and we stage it out over a long period of time. And so we've learned that we need to tailor the treatment to the patient, all the elements of the patient, not just their genetics, but what's happening to their aorta, what their own personal desires are in life, and we can provide this lifelong care with this kind of hybrid care. But we've been more aggressive about using the endovascular technology. So a Turner patient of mine just this last month came in with an acute dissection. Pretty cool. She was 30, just like your average was, 30.7. I saw that. She was 31. She was in the hospital being treated medically with this, had recurrent pain. And you can see her aorta was not very dilated. I think it was like 3.7 or something. It was an ugly looking tear up at the top of the aorta, and I saw her along with the vascular team. And I said, we should just treat this. She's got good landing zones. We've got good devices. She didn't have a bicuspid valve. There was no rush for us to do anything in her proximal aorta. And so we did. We brought her back at 4 weeks, a lot like the discussion we had yesterday in IRAD during the subacute phase. And this is what the procedure looks like. We use this TBE device. So we got double wire access. We deploy the device in the aortic arch, just proximal to the left subclavian artery. We then made an exchange, delivered the branch into the left subclavian artery. This is all kind of melted together. It doesn't happen this fast. And we deployed the second component in her left subclavian artery, and then shoot an angiogram when we're done. We make sure we don't cover the left vertebral artery. We balloon these devices together to make sure we've got good seal everywhere. And again, it's been my approach to treat a whole lot of the aorta with these bare dissection stents, because I'm taking a bunch of them out, and it's no big deal if I have to do an open repair. My idea is always don't burn any bridges. And so we did that. So we extended the bare dissection stent all the way through. Here's the TBE device in the proximal aorta. And you see we got our whole aorta covered. And here's the post-op CT scan, and it looks great. So we've got most of that dissection thrombosed through at least all of her thoracic aorta, and now we're on a plan to monitor her, and she did great. She went home in a few days. So advantages of TEVAR are that it's safe and expeditious, and I would say that open and endovascular therapies are complementary to one another. There's a whole lot of other things we can do in dissections. We've created this crazy looking schema for chronic dissections because we have all these therapies at hand. Now the question is why and how to predict this was the question that I was also given in my assignment. And I know I'm tight on time, and I'm going to blow through this, but I think this is really important because we know that these dissections happen sometimes at normal size. We'll hear a lot more from a lot of people smarter than me about why this happens, but I think the point is it happens at a micro level in the media of the aorta. And Jay's speaking as well, it's maladaptive remodeling. It's some things that we can affect about the hemodynamics. Maybe one day we'll be able to do some really cool imaging to help us pick out when someone's at risk for having a type B dissection, but not really, not now. Now we still go by size. And so what we've done is with my lab, I've got a bioengineering lab, and we run this what we call a Matadors study, which really we're not focused on any one question, just we gathered a ton of data so we can answer a whole lot of questions, including imaging, a lot of tissue harvesting, histology, and all of the omics are available to us. And in the 353 patients I've enrolled with tissue specimens, we've got a lot of them who have known disorders. 48 of them with familial heritable thoracic aortic conditions. Some of this early work that I did along with Sunil Apte, we identified that there was massive accumulation of aggrecan and versican proteoglycans in all the specimens, regardless of what the cause was. They had a similar sort of outcome. I see the patients at the end of the disease state. We confirmed this in a mouse model. We saw and came up with this idea that this accumulation of proteoglycan is an important problem for the pathophysiology because of loss of adhesion and mechanical sensing. And again, I think we need to stop thinking about aortic aneurysm and dissection as diseases, but as complications, late complications of the underlying cause that all of you are working so hard to study and teach us about. And so we also had this idea that maybe it provided a potential biomarker. And so after we learned this, we got smart about doing some biomechanical testing in my lab. We figured out a bunch of things. We wrote a few papers. Somebody linked onto this, and they studied it in a few patients and found that there was a lot of aggrecan in their dissection experience, although this was sort of hard to assess. But we focused on it. And this was a presentation just from this year's aortic symposium from Ben Kramer, who just became a PhD out of my lab. He's a general surgery resident, amazing guy. So we looked at 163 patients. We had some healthy controls, and we had some surgical controls that underwent coronary bypass without aneurysm or dissection. We gathered serum plasma and arterial venous through pre and postoperative phases. We did the biomechanical testing on a bunch of the patients that had surgery. It wasn't all of them, but it was a lot of the patients, and we had a lot of samples. We did unilateral biaxial load testing, and we found aggrecan was strongly correlated with aortopathy, and it was not present in any of our controls, either the coronary patients or the normal patients. We also found that it correlated with some other factors like the length and the diameter of the aorta, and we also found that it correlated with some of our biomechanical testing on the tissue, like in the delamination testing, as well as in the biaxial load testing. The higher levels had weaker aortas with regards to energy, strain energy density. And so we think that this is a novel biomarker for aortopathy. We know that it's correlated with worse mechanical behavior, certainly in the lab. And venous blood samples are really easy to detect and actually the best. And so we hope to learn how to use aggrecan as a potential biomarker to help us in decision making. I have so many patients between 4 and 5 centimeters we don't know what to do with. I'm hoping that in the next year or two we'll show you what we've learned from taking some samples from them in the outpatient clinic, and maybe we can use this like the urologists use PSA. Thank you very much.